Good afternoon, everybody. Great. Thank you for all being here. My name is Andrew Kaplan. I am the Senior Vice President for Public Affairs at Takeda. Thanks for joining us this afternoon. And we were just joking, a little bit after lunch, before drinks. So hopefully everyone's brought their energy to the afternoon moment. I'm joined by a tremendous panel of colleagues and friends. And we're going to talk a little bit about obviously what it takes to be community-based and really make a difference in the communities that we all live and work. I'm fortunate Takeda's U.S. presence is based in Cambridge, Massachusetts, and many of our colleagues are partners of ours in Massachusetts. So it'll be exciting to hear a little bit about kind of their experience and what they're focused on. Maybe to set up the discussion a little bit, you know, in the U.S., an estimated 1 in 10 people lack adequate access to healthcare simply because of social factors. The importance of addressing social determinants of health to drive long-term community health is really obviously at the core of what we should all be doing. Takeda's long history has told us that real challenges don't happen inside the walls of our company. It comes through the partnerships we make in the community. It happens because of the people here and the trusted partners in the community that we live and work and breathe in, and that it's best to design solutions through those community partnerships. It also comes through building coalitions. We're really happy to be here today to have a conversation around the challenges these specific communities face, what drives successful community engagement and initiatives, and what are some of the key ingredients that we should all take away as we think about this moving forward. So we're going to not have everyone do their bio, because that'll take too much time. So we'll let everyone say a little bit about what you do and where you work as we go through, if you don't mind. But maybe let's kick off the conversation with my colleague to my left, Sema. So kind of as we think about this question, how do programs create better health at the community level, whether through policy system changes or targeted interventions and to remove barriers in healthcare? You know, Sema, I know for you, your experience is really about social data and behavioral health data. And identifying and addressing the health risks and the needs. Can you talk a little bit about what you think really kind of works there?
Sure. Hi, everyone. Good afternoon. Great to be here. So very quick intro. I'm Sema Sagayer. I'm the co-founder and CEO of Sorgo Health. We're a public benefits corporation and work a lot in understanding communities through data. Well, the number one thing I want to say is, first of all, when we're working in communities, we actually know a lot about our communities, right, Reverend? I'm sure you work in your community and know. But I think one of the key ingredients for me is how do we move from intuition, which is what we think we know based on who we see, to conviction, which is, do we really know everything about the communities, right? So there are people that walk into the door, but there's also a host of people that don't ever walk into your door. And so, you know, when we look at healthcare, one of the important things is really understanding how people relate to health, what are their experiences, and what are their barriers. Just to give an example from this morning's, we had a breakfast which was really interesting, and there was a statistic that was shared, which is, don't quote me, but roughly, about 15% of people that have actually health insurance go and do their their physical exam every year, which is a very, very low number. So it's not like you don't have insurance, you actually have it. But why is it, right? And so for some people, it could be a matter of time. For some people, it could be maybe they never found the physician that they want that actually aligns with how they're thinking about health. For some people, it may be access. But there's so many factors that determine that, and I think we'll get into more detail. Understanding those at a very local and individual level is the only way I think we can think about how to do community outreach, how to develop policies and programs in a way that actually aligns with their needs. And that's where I think data plays an important role to give us that full picture.
Thanks, Sema. Maybe, Reverend, you can kind of build upon that and talk a little bit about, you know, as a pastor, you're seeing kind of the impact of social determinants of health all the time.
Yes.
Can you speak a little bit about the growing burden of disparities that affect your community today and how we can better address them?
Yes, thank you very much. First, my name is Reverend Willie Bodgick II. I serve as senior pastor of the historic 12th Baptist Church in the Roxbury community of Boston. I also serve as president and CEO of the American City Coalition, where we focus on economic development, workforce development, research, and policy. And the question is so poignant because the social determinants of health, I hear it in prayer requests, I hear it in conversations, but for me, it's centered in our work is in the gospel. Jesus says in Matthew 25, when I was hungry, did you feed me? When I was thirsty, did you give me something to drink? We have a theological underpinning for the reason reason why we're addressing the social determinants of health. It is food insecurity. It is job insecurity. It is the education and opportunity gaps. It is the housing market that we're dealing with right now in Massachusetts. And so what we've been trying to do at 12 Baptist Church is to meet those needs. We have a food pantry that we fed 15,000 people every year out of our food pantry. And if you come down Warren Street on a Tuesday, you'll see lines all the way down the street. It lets you know the real need that is present in this moment. It also, we have an after-school program. We also do global outreach where we're working with organizations in Rotan, Honduras, and we're working with a school in Liberia. So we know that these needs are not only present in our community, they're present beyond us. But the thing I think is most important around community-centered based work that we're trying to do, that before we even get to the policy, before we get to the program, we start with the people. People have to be centered. People over numbers, people over policy, people over programs. And if you start with the people, you can build meaningful programs. You can build meaningful policies. You can do the work that is necessary. And so I think you're so right when you talk about place matters. Place-based approaches matter in the ways in which we're engaged in this work. I also believe that relationships matter. I personally believe that trust goes further than any policy or program. And so the relationships that we build, the people that we serve each and every day, the trust that we have built, I think serves best for healthcare and the partnerships that we're trying to make in community. And I think it is the opportunity that we will have. And we saw that during COVID, which we'll talk a little bit more about. But I think it is the foundations of trust that people understand where they are, they know their experiences, and they know the institutions, the champions, the stakeholders that they trust to be able to do the work they need to do to create the wholeness that people need in their lives.
Yeah, I mean, I think trust is central to so much of kind of life and society and how you engage in those personal, interpersonal relationships. You mentioned food for a minute, which, David, is a nice segue to kind of what you spend your day thinking about. Many people think about food access and nutrition as separate from healthcare. What do you wish more people understood about the role of nutrition in treating illness?
Thank you. Yeah. I'm David Waters. I'm the CEO of Community Servings. We are a medically tailored nutrition program that serves the states of Massachusetts and Rhode Island. I've been in the field for 35 years, long before the term food as medicine was coined, back when we were feeding people with HIV. And there are three quick things that I would touch on. The first is that while we say food is medicine, food, of course, is not medicine. And if it tastes like medicine, we're not going to enjoy it, right? So the first thing, if you want to engage anybody, it has to be delicious. And so even though we live very squarely in a healthcare space, we think a lot about local sourcing, scratch cooking, culturally relevant, et cetera. The second thing is that the meal that each of us gets in the room is different based on what our health needs are, right? So if I said to you as my new bestie, would you run and get me supper tonight? You might say yes, until I awkwardly say, oh wait, I need a meal that controls for glucose, potassium, phosphorus, vitamin K, and sodium. And your eyes would glaze over and you'd back out of the room. But that's a standard diet for diabetes. That's somebody with advanced diabetes. My best friend had that diet. And yet, if all of us, most of us who've grown up in some degree or experienced privilege in one way or another, if we don't know how to do that, imagine if you strip away stable housing, money in the bank, we speak English, we don't have literacy issues, we haven't lived our life in systemic racism, et cetera. And you see where the system sets people up to fail, because if you don't know what potassium and phosphorus is, you can't go to the store and pick the right meal. So a program like ours tailors the food to address multiple comorbidities or multiple dietary restrictions. And that's really the power of it. And then the third piece that really brings into healthcare is the data piece. So our first research study, we're one of the largest research facilities for this work in the country, but our first study was funded by the Robert Wood Johnson Foundation. And it was published in JAMA. And what it showed was we looked at people we'd fed over 5 years, and we looked backwards in partnership with the state to look at their billing records. And we said, what happened when we were feeding them? And we had no idea. But what we discovered was we were saving 16% net of the cost of food on their total healthcare costs. They were 49% less likely to go in the hospital, 72% less likely to go to a nursing home, 70% less likely to go to the emergency, less likely to use an ambulance. If we save one night in the hospital, we save enough dollars to feed them for 6 months. So it's with that data that we made the leap from food insecurity, or what we would now call nutrition insecurity, into healthcare.
It's so great that you took the time to measure the output. I think it's one of the things that we really struggle with. You know, the data is really important, but I think showing people through empirical data is what's really going to drive people to take it to heart. And so it's a great moment there. Maybe Christina, as we kind of close out this first little bit here, to reimagine a healthcare system in the U.S. to be truly equity driven, we need community center policies. Can you speak about the work that Partners in Health is doing, specifically in Massachusetts, where I know you spend most of your time, and how it can be a model for others who are driving kind of similar long-term initiatives?
Yeah, thank you, Andrew. Hi, everyone. I'm Christina St. Cyr. I'm the Massachusetts Director for Partners in Health US. Partners in Health is a global public health nonprofit organization. We work in a number of different countries across the globe, and we also have an arm here in the United States. I want to build a little bit off of what Willie was saying, because I think the trust piece is what really resonated for me. So at PIH, we have this model called accompaniment, and this is a model we use in all of our work all across the globe, and it's really trust-based. We say that the work moves at the speed of trust, right? And so it's really going in, building these partnerships, whether it's with community-based organizations, whether it's with governmental entities, public health departments. It's around coming in and listening first and hearing what the needs are from our partners, that we're trying to build this relationship, this trust, and then we do what they are saying and what they say is needed, right? And that's the accompaniment model, coming in and not coming in with our own agenda. We might have resources, we might have connections, we might have stories and data, right, from other work that we've done in different areas, and we can build that in, but we really want to come in and listen to the community members that we're working with and the community partners, so that we're hearing them and can really apply the work well. One of the models that we have been implementing in Massachusetts and the city of New Bedford, and I have to give a shout out, I don't know if anyone was at Damone Chaplin's panel earlier. He used to be the health director for the city of New Bedford, so he actually came up with this concept of a health equity community of practice. And so in Massachusetts, we do the work twofold. We do place-based programming, and we also do state and local policy work for that broader systems level change. And so this model is really sort of combining both. We've been able to bring together over 164 different community organizations from across sectors, all within the city of New Bedford and, a little bit broader in that region. And what we were able to do is everyone comes in, right, wearing a different hat. David would come, he'd be wearing his food systems hat, his, food is medicine hat. Willie will come in with a different hat. So we brought all these players together, and we said, we need to focus on health equity. So first of all, what does health equity mean? Let's level set. Let's make sure we all have the same baseline understanding. And let's think about what are the true needs of our community. And so we were able to go through this process of identifying the top needs. And there's so many, right? There's always so many priorities. And so how do you hone in, right? So we had this group prioritize, and we came up with 3 different priorities. And everyone was able to take their hat off. They still can go do their work, but we all came together to advance 3 different priorities. So around community health, mental health, and civic engagement. And we went even further, because to me, I was like, those are so broad. Like, come on, guys, that's a cop-out. But we really honed in on then policy solutions that we could work together so that we're actually moving the needle, right? We have to work together in order to move that needle and to really advance community health and health equity. And so that's been a really powerful model that hopefully we can share a little bit more throughout the panel.
Thanks for you've all talked about the importance of trust, but I think, Christina, you were just talking about the importance of kind of allyship, right, and partnership, and that's what really does drive a community. We know that at Takeda, we can't do anything by ourselves, right? There's very little I ever get up every day and I'm like, oh, we're going to do this by ourselves and hold out that we can do it. It's going to be with folks like yourselves and others in the room who really want to make this the reality of how we work. So maybe transitioning a little bit to this idea of allyship, and sometimes really where you find allyship is in the most uncommon places. David, can you talk a little bit about, like, what do you wish more people understood about what it takes to build that diverse coalition? And can you tell us a little bit about the incubator that you serve from Community Servings?
Sure. So we work with lots of allies at the direct service level, at the community level, partners that, whether it's, one of the Coalition of Black Churches or something like that in our work, but specifically on a sort of systems change level, most food as medicine programs, medically tailored meal programs grew up in the HIV epidemic, which was in urban areas and generally, roughly speaking, on the coasts. So programs grew up in what we might now call blue states. And yet, as you build a movement and you want to believe, with the kind of data that I referenced, we believe that Medicare and Medicaid ought to reimburse for this service anywhere in the country. Well, you can't do that and live purely on the coast, metaphorically speaking. So how do you take what we've learned in an urban environment and look to a rural environment or a Midwest environment or a Deep South environment? And so in order to do that, we've built an incubator, what we call the Food as Medicine Accelerator. And we work with programs around the country that are already working in the food business, nonprofits, food banks, Meals on Wheels programs that already respect high quality food, scratch cooking. And we teach them how to work in the healthcare world and how to turn their perspective into healthcare. So who to talk to in healthcare to get a contract, how to understand pricing, to price your service. Everybody in the nonprofit world, we undersell what we do, and we think that we can't charge full price, but if you're going to be successful, you have to cover all your costs. So we work with organizations like food banks to develop their business plan, their pricing model, who to talk to, their pitch deck, but also things like data security around PHI and that kind of stuff. And with that, we've graduated, it's a one-year intensive curriculum. We've graduated 15 new programs, and 5 more will graduate this week. So cities like Houston and Chicago and Cleveland and Tampa and Orlando and Phoenix are all new programs we've created around the country. But to that diverse allyship, it's also a policy strategy, because if we're going to go to Congress or the administration and we can connect with leaders from red states as well as blue states or people from different perspectives than my own, that's that rich coalition of programs that know what it's like to be in all different communities. I think is really important.
So partnerships are really important. One of the things that's really interesting is, Sama, is the concept of data and how can they help you find new allies. I know, we've used a lot of work at Takeda on my team trying to identify people who are working in the same space so that you're not kind of cold calling people, which is what I've done a lot. With little success, I've come to find as well. Kind of what role do you think data plays in identifying kind of allies in that regard?
Yeah, I'll give a real example to illustrate. So this goes back to my community where I live, which is Washington, D.C. And we, had developed a lot of data around understanding maternal mortality and morbidity in the U.S. As we know, U.S. has some of the worst outcomes. And so we wanted to do something in our community, and so we went and actually in DC, zip code by zip code, mapped all of the maternal mortality and really mapped all of the upstream drivers of maternal mortality to understand where are some of those zones or areas where are quote-unquote deserts that really require a lot of help, have high mortality but also high need. And what was really interesting when we overlaid a lot of different data sets is the areas that had high mortality and morbidity were also areas that, one, were far away from birthing facilities or healthcare centers, but number two, were also not in any line of transport system, from public system, whether it's bus or metro. And so we're like, okay, how are these mothers, right? And we know, for example, pregnant women going for their antenatal visits is a really important healthcare activity that they need to do to save their baby's health and their health. And so we said, how are we going to do this? So we went to federally qualified centers in DC. There are 2 really big ones, and we sat around the table with them and said, hey, look, there are these areas and there are these women. They're like, yes, absolutely, we know. And look, there's also these gaps. And so we brainstormed together and we said, what if we got Uber to partner with us and actually offer free rides to these women so that they can make their antenatal visits. They were like, oh, this is an amazing idea. So then we went to Uber, but that wasn't enough because we also had to think about how to bring the service to these women who don't necessarily have credit cards or who are not comfortable, putting a card in their phone and the way we are so comfortable doing. And so then we designed with the Fairly Qualified Health Centers, with the women themselves as well, and with Uber, we sat around the table and designed a very women-centric approach of how to provide rides, and we came up with 2 models. One model is that there is someone in the Federally Qualified Health Center who's going to call and actually schedule those rides, and another was giving them vouchers and doing it through. So it was very centered around their needs. And it turned out to be a really effective program. We actually also evaluated this program. Going back to the evaluation, we actually were like, this is a one-time opportunity to actually lay around an evaluation, and had really positive results. And now it's actually being scaled with Medicaid across the country because it's been so powerful, both in terms of outcomes, in terms of the women's experience. We also were really interested what was their experience. And so I think this is a good example of kind of that journey of starting with data, identifying the problem, the potential solutions, and then thinking out of the box, who could be those allies that could really help you close that gap.
I also love that you talked about not making the assumption about that the women would just be able to have a card, right? I had a conversation years ago with some policymakers. We were talking about giving people access to technology. And I was like, well, everyone can just use their phone. And she's like, you're assuming everyone wants to use your data plans for that reason. They might need their data plans for a totally unknown reason, like they need to call an ambulance. And that's the most important thing they need their phone for. So it's really, I love how you didn't make the assumption along the way as to what the right answer was for that individual.
But I learned that the hard way because I made a lot of mistakes in my career assuming what communities want, putting programs together and seeing them fail. So it comes from failure.
The best types of learning I think we all find, right? Like failures, as long as you do it fast, and as my boss would tell me, you don't do it more than twice in the same way, 3rd time you're out. That was kind of the rule of thumb. Willie, maybe just a little bit about kind of faith-based organizations and how you guys really do serve as that foundation in so many communities, creating kind of that trust and promoting kind of that health education importance. Can you talk what it means to then bring kind of allies into that with you?
Yeah, thank you very much. I think before we get to allies, we have to get to a place of alignment. Because I think sometimes we rush to this place of allies because we believe everybody is well-meaning. Yep. But many a times, we're not always aligned in how we're actually going about thinking about the work or even doing the work. And so I appreciate what you're saying in the sense of there's an opportunity to broker true understanding of one another. The best example I can give is COVID-19. Of an uncommon allyship. In many ways, I believe that the healthcare system has paternalistically at times engaged faith-based communities. They come to us when they need to get some type of testing done. They come to us when they need to find out some information. Sometimes they come when they need some data to justify it. And many a times, it's not always building relationship. And so you create this greater chasm between institutions and many of the folks that are there who are also the patient populations of many of the healthcare systems that we're engaging. I come to COVID-19 because I'm very blessed to pastor a church that's 220 years old, since the African Baptist Church, 185 years as 12th Baptist Church, and I'm the 14th person since 1848. And so we've been through a lot of epics of crisis. We were one of the hubs on the Underground Railroad because of Leonard Grimes, and we were known as the Fugitive Slave Church. In the heat of the Civil Rights Movement, we were one of the meeting houses and the places that people came to gather and to organize. And in COVID, we knew that it was our generation's time to meet that moment. Crisis does something to us. It reshapes and reorients us, and it drives us in a way that comfort does not. COVID was very tough for so many of us, all of us in many ways. I, unfortunately, had to put a lot of people in the grave, be with them in very vulnerable moments. And I realized the immediate impacts of COVID-19 because I had a lot of frontline workers who were congregants in my church, folks who didn't get to work from home. They had to go deliver the mail. They had to go into their grocery store and work, or that Walgreens. They had to go and do that work every single day, and they weren't protected from the exposures. And so you had these real moments that were happening. And because of those real moments, and then my wife is also a physician, so we're always having these conversations, we were trying to figure out how do we stop the bleeding. COVID-19 was tough because we were dealing with multiple pandemics paralleling at one time, right? You have the disease and COVID-19, but you also have the misinformation that's happening. You also have the distrust of healthcare. And then you also had the George Floyd moment that we all were living in and were captive to, which erupted protests, rightfully so, all across this country. And we were navigating all of these moments while still at the end of the day trying to make sure that people stay safe, people stayed alive, people had opportunities. It was at that moment I was reaching out and calling healthcare centers, calling hospitals. Some folks didn't want to go that far, they didn't want to do that, but what we realized in the state, being on calls with the governors and with the mayors, is that they weren't getting the vaccine out fast enough. And the people who were most vulnerable wasn't getting it. And so we said we have to change the way in which we do this. We have to change our orientation. And through a lot of advocacy and working with Boston Medical Center, we said, look, we're going to do something different. I said, how about we come to the church and we work and build out a clinic at the church? People aren't coming to you, and there's a host of reasons why, but I know where they will come. They'll come to the church. And Boston Medical Center was more than amenable. There was alignment for us, because many of our congregants are their patient population. It's proximate. When you talk about transportation, I really appreciate that, because my pitch was, we got a bus stop on both sides of the road. We have the largest parking lot of any church in the city. I mean, you have to use the assets that you have. And you can walk from Nubian Square and from Boston Medical Center to our church. It's less than a mile away. We are the perfect locale to do this work. And Boston Medical Center said, well, let's make it happen. And so we worked it out internally. We did everything we needed to do. There was a lot of regulations from state and local regulations and city regulations about people and capacity, as you all know very well. But what we did was we said, we're going to shut down our fellowship hall area. It's a big space. And we're going to retrofit it into a clinic. And we created a vaccination clinic, and we did that. And that was there for over 6 months, where we did that in that clinic. And it was available to every single person. I didn't care if he was a member. We didn't ask for any status of anything. All you had to do was walk into the church, because the church has always been a place of refuge and healing. And that's the message we wanted to go out to, not only our community, but our city, but also to our Commonwealth. And so, when you're talking about these partnerships and what we must do, we have to understand, because my big idea is that churches and faith-based organizations are the most underutilized assets in public healthcare today.
For sure.
And we can change that, because we've had to do it before. Mm-hmm. And for some reason, we've had a lot of institutional memory loss since COVID. Maybe folks are trying to forget it, sweep it under the rug. But for some reason, we can get everybody to the table at one time during that moment. And so I'm hoping that as we talk about partnership, that it's not just about moments of crisis, but that we treat moments of comfort as we do in crisis. And I think we'll start to see the outcomes that we want to see, because the infrastructure is already there.
Yeah, it's such a great point, right? You guys, faith-based organizations are the center of almost any community. And we found that in our work that we do in Georgia with a church down in Albany and a group of folks down there. Same concept, right? They're the ones where people want to go first, and they're the ones who are the most trusted. The alignment's easier there than it is anywhere else.
You're right. And just to add one quick thing, many of members pulled me to the side. If you didn't do it here, I wouldn't have gotten it. Right. That was the difference between life and death for some people who had comorbidities that were already present.
Yeah. Yep. Yeah.
And so it matters where we do the work. It matters who we partner with when we do the work. And I think, one thing I got to give BMC credit, because they worked with me. We did information sessions. We dealt with it. They came on our peace walks and we talked about the issue. Everybody didn't agree with the vaccine. And so we wrestled with the theological issues that arose. We did fireside chats. We had conversations. Brought physicians in from BMC to kind of talk through and answer all questions. And we did that ad nauseum, because it was worth it in that moment. And so I think that's important. And the other thing, and the last thing, and I'll end here, you can't tell people to do something you won't do yourself. So the first person to get the vaccine in my church was me. And we took a picture of it. They put it on video. We did Instagram posts. We did all this. They put it on a billboard that's still up there
I did notice that,
in
right?
Roxbury. And I've been asking them to take it down. But you can't preach something on Sunday
Right.
and not live it the rest of the week. And so we try to make sure we do that. We try to break down the chasms between faith and science because it doesn't have to exist. We can do the work together.
Yeah, I mean, maybe just taking it one step further, Christina, you talk a lot about going, your organization does, about going from kind of like talking to doing. And allies are great sitting at a table, and you were referring to that earlier, but it's really the moment from when you're an ally and aligning at a table to then kind of implementing that change. Like, what does it take to get there?
Yeah, that's a great question. I mean, I love the topic of the uncommon allies because I think those of us, all of us in public health, right, we know that everything is public health, and so we are always looking to partner with so many different people in different sectors because we see how like economic development impacts health and we see how transportation impacts health, but those in those fields don't necessarily see that. So I want to touch on 2 points. One is those like uncommon allies in sort of the traditional sense, right? We work for organizations, we partner with other organizations. And then I also want to talk about the allies that I think are not brought to the table enough, and those are the people who are most impacted by the work and the policies that us allies are working so hard to figure out. So we have been supporting a really innovative project in New Bedford called the Equitable Approach to Public Safety program. And so this is a partnership between the health department, the police department, and 2 community-based organizations who offer mental health services. And so the goal of this program is to be able to divert individuals from the criminal justice system, which I think is a whole other crisis we could talk all day about, and also divert them from the emergency room system, and instead get them to the actual care and resources that they need in order to get better, in order to thrive, in order to live their lives. And so we've been able to help coordinate this through a co-response model. And it took a lot of coordination, it took a lot of getting people to that table, right, who don't necessarily work together on a day-to-day, and really provide an education to our partners within the police department on understanding the value of this, so that we can have clinicians do ride-alongs. We were able to train the dispatchers in the city so that they can send out clinicians to behavioral health calls. And the city gets over 300 calls in 1 month for behavioral health. So to be able to have, someone show up, and I could talk about some of the numbers, but I will let someone do that. So what I wanted to...
I don't know, I'm not on this one, don't worry.
That's her expertise. I like the stories. And so, I mean, just think about from the impact side of the individual, you're suffering a mental health crisis, right? You are scared, you maybe are confused, you're probably feeling stressed, and then you have a police officer show up, right? And that's just going to exacerbate all of those feelings, even if they are well-intentioned, even if they're there to help. They don't necessarily have the skills to de-escalate that situation. And so when you have someone come in, like a mental health clinician, who is trained in crisis intervention and can be the first person to interact with you, that completely changes your trajectory, right? You're no longer going to be put into a jail cell in the criminal justice system, which will have repercussions for years to come potentially, and you're also not going to go sit and wait in an emergency department in a different colored gown where you are singled out for having mental health challenges, right? So this is having a huge impact by just bringing a couple of different players together. So that's one piece. And then the second piece was those who are most impacted, right? And so I just want to bring us back to a little bit of history. If you think about some of the big public health wins over the years, someone brought up sidewalks earlier, and that immediately made me think of curb cuts. So who were the biggest proponents for getting curb cuts into our sidewalks, right? Those who are physically disabled, those who are most impacted. But who does it benefit? I know I'm tired sometimes, and I don't want to step up the curb. I know I'm also pushing a stroller, right? So moms, parents who are pushing something. You have a cart of stuff that you're lugging from one office to the next, right? And you utilize that curb cut. You also think about, how did smoking get out of airplanes? It was the flight attendants who are the ones who are most impacted, and we're pushing for that. But who does it benefit? It benefits all of us. So I think the uncommon ally that we need to talk about and bring to the table more are those individuals who are the most impacted by these challenges that we are facing, right? And so I don't have all the perfect answers because it's a really challenging piece to bring people in who aren't doing this for work day to day, right? We have our meetings 9 to 5. We all get paid to do this work, and we care about it, and we're passionate, and maybe some of us are from the community, and so we have that perspective, and that's great. But how do we think differently about really like meaningfully engaging folks who have these lived experiences and making sure that there is a model and a place for them? One of the things with the EAPS partnership is we're working to build a community advisory committee to be able to provide some input on this particular model, but also just additional ways in which we could be working better with the community to address some of the challenges that they are facing. So we're really excited about expanding that and really listening and bringing those voices to the table and having them play a meaningful role in future solutions.
It's so great to hear you talk about it, because I think one of the things that happens when we all sit down and try and solve a problem is we think about the most likely people who want to work with us, right? It's somebody in the community who you know. It's not the person who you read about that you haven't called or you don't know. We all make assumptions about who the right ally is, or because of influence or some other reason, but we might not make the right assumption about who's the random person that you met on the street that has the same shared interest as you, and maybe I should call them to see if they're interested as much as I call my friend. I would flag for everyone in the audience, we're gonna do one more question, and then hopefully you have questions. So think hard. This is what we do at the company, right? No one asks questions at the company. It's a problem. I gotta then, hopefully that won't be the problem here. Maybe coming back, somebody to you, we talk so much about measuring and kind of really, if you measure for success, you can scale the solutions. Can you talk a little bit about what you've learned and I won't say just the metrics, but the most important metrics that you measure as you go through these moments, and what really does make a difference in your research that you've seen so far?
Yes, so I can talk about what people want to see and what I think we should also be measuring.
It's important to do both.
Yes. Well, I think when people want to, we do a pilot and then you want to scale it, everyone wants to say, okay, show me the impact metric. Show me the ROI. What is the return on my investment? That's all good and well. Sometimes you don't have enough time to be able to show those things. So I think we all need to be very realistic in terms of what is the impact metric that we can measure. So for example, going back to this Uber case, the pilot was 6 months long, and there were certain people, that were asking us, well, show me how maternal mortality changed in DC. I'm like, well, that's not going to happen. It's just not realistic, I know. But it takes a bit. Like you would be surprised what people are asking. So I think one is just like, what is realistic and what can be measured. But I do think something that is really under measured is the personal experience of the people that we're working with and helping and changing their lives, right? How has their day-to-day changed? How do they feel about it? What has been their personal experience? So again, in this Uber case, we really wanted to understand kind of the women's perspectives, right? How did it impact their daily lives? How did it impact their happiness? Did they feel that this actually freed up more time for them to do other things? Really measures that may not be the traditional quote-unquote public health measures that people want to quote-unquote then scale. So I guess my pitch would be realistic, but also really think about what truly matters to the person that you're trying to really reach, and you're really trying to deliver a particular service, and make sure that you're also measuring that, because at the end of the day, we are really trying to help the community, and so that's critical.
Great. All right. Ooh, awesome. I love questions. All right. You were first over here, sir, so I'm going to go to you for sure.
Thank you. Pastor, all of you, thank you so much. Pastor, you're a master strategist, I can tell. And I'm just sort of curious what it has been like for you to try to develop partnerships, so-called secular partnerships. What was that like for you? And were there some that said, well, this is a church, we can't do anything with the church? And were there others who didn't really think about that so much? And what do those relationships look like now? Is that work pro bono? Do you have to pay for some of the things? And my second question is, take us out 4 or 5 years from now. Who are some partners that you want to bring online to take the ministry even further?
And Try and be quick, because we want to get to
Try and be
others.
quick. All right.
Interested party here.
Got you. I'll be trying to be as concise as I can be. I think I was telling someone in the room today, my experiences before I was senior pastor helped me a lot. I was very, very blessed after leaving Harvard Divinity School to go on and to work in politics very heavily. So I worked for Martha Coakley, for Deval Patrick. I got to go and work for Mar Healy, who's the AG, who's now the governor. And I ran outreach for the state for Massachusetts at 26 years old. So I got to see the Commonwealth in a way that most people didn't. And I got to, go to Rotary clubs. I got to go to elementary schools, but I also got to go to corporations and see how things were actually working. So I think it gave me an experience and a tool set to execute in a way that was different. I also was at a law firm at Brown Rednick for some time after I finished law school. And so I think being able to kind of navigate and to be able to understand that there are people who see the church as a partner on per need basis. And I demand of them that we have more meaningful relationship than that. That I don't want you to just pop in because it hits your agenda, that this may be a good place to come and show up. It happens with politicians all the time, right? Everybody knows what a black church is when it's election season. And so we want to be honest about what type of work that we're doing, because most of it sometimes can feel transactional. And I don't think our community deserves that. And so I ask and demand that. And I think sometimes people underestimate the church. We have many professionals that are well qualified who are running many of things in the city that are members of our church. You may not know them in that capacity, but they're there as well. And so, we try to be very intentional about how we do partnerships. We're doing this work beyond the scope of just was COVID. We're doing it around prostate cancer awareness, and we're doing that very meaningfully. We're doing it around mental health and mental wellness. We're doing it in partnership with other churches as well as with hospitals, and looking for research funding and capital. And so I think for me, I think there are bigger partners to do that. Takeda could be a great partner.
As we were talking yesterday.
No.
See, he's not shy one bit.
Not shy at all. No, but I think they're partners who we want to develop meaningful relationships with, because one thing I have learned, and I'll stop right here for the sake of time, I also recognize that I don't have to know it all to be able to service this community. We want to work with people who have more expertise, who can do the work of capturing data, who can do other things, because the church doesn't have to have all the answers, but if we partner meaningfully and the relationships are built upon the foundation of trust, then we can actually achieve the goals that we all want to achieve. So,
perfect. All right. I think your hand was second, then I'm going to go to that side of the room. So, nice lady here in the jack. Hold on one sec. Ooh.
Thank you so much for a phenomenal conversation. My name is Suzanne Henderson, and I lead the faith and health sector at Interfaith America.
Oh, beautiful.
And our work is national in scope. And it's just so heartening to hear you articulate exactly what I had said to my seatmate before the session started, which is the under-recognized potential of these really deep and meaningful and not extractive engagements of faith communities of all stripes, because at the core of every religious tradition is an impulse toward health. Right? So my question is an unanswerable one, but I would love anyone's thoughts.
We only have 6 minutes left, so let's just be clear.
I would love anyone's thoughts on how we bring this sort of faith and health intersection from niche to norm. How we elevate when I've been in lots of wonderful public health conversations this week, and I've heard scant mention of this dynamic. How do we raise, for the future public health leaders of our society or clinicians, raise an understanding and maybe even lower some suspicion around engaging religion and spirituality in service to personal and public health?
Can I maybe mix it up a little bit? Give everyone, David, can you maybe take that for a start, since I know you do a lot of coalition building, and I know the faith-based community is part of that?
Yeah, thank you. There's so many ways to answer that, but the thing that's been burning in my mind is the Reverend's description of COVID and using the church and working with the clinic, et cetera. And I'm thinking about the moment right now that many of us are in, and many of us are anxious about. We're in an inflection point in healthcare and public health. And I don't think it really matters what your politics are. It's still an inflection point, good, bad, whatever it might be. But to go to the spiritual, I think we have to find some optimism in the midst of that. And your example of COVID was so powerful. You know, that on the one hand, you were burying parishioners and how heartbreaking that is for each family. And yet what was built out of that community building in the clinic was something really good. And the way that I tell my own team how to get through this is that we've survived everything else. We survived the AIDS epidemic. We survived the crash of 2008. We've survived COVID. We will survive this now. But I think we also have to look for not just negativity in terms of survival, but also what are the lessons to learn from this? And I know it's not exactly the question you asked, but I think that spiritual element to it is really what will keep us centered at a time when we feel very disoriented.
I'm going to go to another question.
Go ahead.
Okay. Over here, Sir with the hat. Yes, sir. You were quick on the hand. I appreciate it.
Thank you. All right. So my question is whether any of you are working on initiatives or innovations in end-of-life care. And I don't mean the last 6 months hospice time. I mean the 3 to 5 years of declining agency, helping patient or member or individual, but also the family or the other unpaid caregivers who are going through, you know, the incredible complexity of the healthcare system along with all of the existential and individual realities. Thank you.
Anybody want to take it?
Go ahead.
You go ahead.
Go ahead, Willie.
Well, no, we're not to fight for it, but because we deal with this a lot. And, you know, we have many caregivers who have the best intentions and don't have the capacity, don't have the wherewithal, don't have the knowledge. So we do a lot of work with the city of Boston, with Age Strong, with a lot of organizations. We're actually putting together a whole program for caretakers. And we're creating a space in our church for anybody who's a caretaker because there's not enough people that do this work that has a community to talk to anybody about it. And so what happens is people end up suffering in silence as they're helping someone that's suffering. And sometimes the care falls and the standards of care is not as great. Sometimes it's a capital issue. People don't have the funds to support and put their loved one in the place where they want to or where they need to. And then many a times it has collateral impacts on the family. And so, you know, there may be one sibling who's taking the low share, or there may be another sibling who's somewhere else, and they're trying to manage this and balance this, and many a times the church has to step up. So usually, you know, we prepare meals for our seniors every single week, and so we provide that for them. But we also bring in experts who are coming into our congregation always to talk about preparations of end-of-life care. How do we prepare for certain situations? Many a times, you know, it falls apart when people do transition. And that's when you see many things fracture families as well. And so, you know, we do this thing where we prepare folks, you know, have your program together. Know what your hymn is going to be. Know the things that you need to do. Do you have a will in the state? We bring in attorneys to come talk about this stuff and do whole programs and sessions around that. I think we have to name it because so many times it's not named and we call some agency from the state or from the city, which would come, but they haven't built meaningful relationships where most of the people are affected as well sometimes. And so I do think, you know, we're doing that work of trying to create a healthier space for folks to be able to talk about that. But I personally have had to step into and intervene in situations where, you know, it sort of just fell apart. Not because they didn't love that person, they just did not have that capacity. And I think it's a conversation that needs to be elevated right now.
I would just add social isolation, I think, is really key. In our work, the person who's calling because they didn't like the green beans is generally calling because they're lonely.
Yeah.
And if they still have the wherewithal to think about green beans, that means that they're still in the land of the living. But recognizing that, and the other piece is the consistency of the delivery person is often the only person seeing that human being before they pass. And so that relationship that they have, don't ever discount the person, you know, bringing something like food. Can be the closest connection you have to the outside world.
All right, so we have 54 seconds on the clock, so you get the last question. Hope it's quick.
Okay, Haley from Talks to Black Breast Cancer Alliance. We are a Black organization, so we work a lot in churches, but a lot individually.
Yeah.
So I'm wondering how we can reach churches at a larger level. That's kind of one, and there is kind of a two, which is younger generations are kind of leaning toward a more holistic approach to treatment. And so just like you reconciled faith and science, I'm wondering how we can do more to reconcile holistic treatment and science and how they can work in tandem. So sorry, 2 questions.
No, it's okay. You're only going to get one answer. I'm sorry. Sorry. That's how life goes. All right. Can you do it quickly, Willie?
Yeah, I think
Make it in 5 seconds?
we should provide opportunities for all the opportunities and resources to be in the space. When we do work around breast cancer or prostate, I actually just lost a really close friend who was 37 years old. She died of breast cancer. It's happening very young and early. There are folks who are catching these diseases very early, and we are trying to figure it out, particularly in our community. And so I think we want to offer those opportunities. We create forums and create spaces, and reach out with meaningful outreach and partnership. And I think we can get that done. So I think, whether I'll be willing to talk to you, whatever city you're in, and connect you with folks, but I know there's national conventions that are happening all the time where folks are bringing those resources in, and I know many churches would love to offer that to their congregants as well.
So I didn't get to ask my last question because I want to answer yours. Do you have something to say? We're good? Okay. I want to thank everyone. I want to thank our panelists for being here and spending some time with everyone, sharing your ideas. Thank you all for spending your time with us, and we hope you have a great rest of the conference. Take care.